The area of targeting BCMA continues to evolve in multiple myeloma, and as per previous meetings, we're seeing a large number of BCMA-targeted agents being investigated. Belantamab Mafodotin, also known as Belamaf, has been reported in this year's EHA. The DREAM6 clinical trial is showing preliminary data, as well as a number of other DREAM clinical trials which are in evolution, and we look forward to additional data coming through. Certainly what we seem to be seeing overall is that the side effect profile is similar to the phase 1 and phase 2 clinical trial, and we're seeing that other agents can be easily combined with Belamaf, which is encouraging and paves its way in the future as a backbone to other combinations. Now at EHA, we're also seeing updates with the CAR-T cell therapy. We saw 2 CAR-T cell updates, one from BB2121, which is the KarMMa phase 2 trial, and also an update on the CARTITUDE phase 1 clinical trial. Now both are BCMA-targeted CAR-T cells. They're both slightly different. The CARTITUDE CAR-T cell has 2 BCMA binding epitopes, but we don't really know whether this lends itself to any difference clinically as yet. The KarMMa clinical trial data, again, continues to show good and high response rates. The median progression-free survival wasn't quite as high as that we saw in the early phase 1 data, but of course, this is probably a more refractory population and is probably more reflective of patients that we want to treat. Again, they've done an indirect comparison with standard of care treatments, and we do see an improvement in progression-free survival with the KarMMa data compared to standard of care. Again, in the CARTITUDE phase 1 clinical trial, we're seeing very impressive response rates with 100% overall response rate, and we're seeing quite a manageable toxicity profile. What's interesting when you compare them like by like is that the kinetics of the CAR-T cells are different. The expansion and the CRS for the CARTITUDE appears to be later than the BB2121, where the expansion and the CRS occurs much earlier on. Now that may lend itself to a different way of delivering these drugs when they come through, but again, we wait and see. In terms of side effect profile, the CRS rates and neurotoxicity rates are broadly similar, with slightly different populations. So it's difficult at the moment to tease them out, but we look forward to seeing more data, certainly from both of them moving forward. Now, of course, CAR-T cells aren't straightforward to give because a patient has to undergo apheresis in a specialist CAR-T cell center. So the other way of targeting BCMA is by using bispecific T-cell engagers. We've already seen results from the Celgene product and the Amgen product in previous meetings, and this year was the time to see Janssen's product Teclistamab. And again, this is a BCMA-targeted bispecific T-cell engager. The molecular makeup of this is slightly different to the previous molecules that I've mentioned. We are seeing very nice response rates, over 70% in relapsed refractory patients. And again, cytokine release syndrome is being observed, and they're looking at a number of different dosing strategies, step-up dosing strategies to try and mitigate this. But I think this approach is incredibly interesting, and I think is probably applicable to a wider proportion of patients than CAR-T cells, because it can be given in centers that are not specialist centers for CAR-T cell therapy and doesn't always require hospital admission, which I think is a major plus point. And finally, these are off-the-shelf therapies, so you don't have to hang around for leukapheresis, cell manufacturing. You can treat a patient very rapidly. So I think there's a lot of potential with these bispecific T-cell engagers, and really what we're looking forward in the future is what is going to delineate between all of these products which are moving forward, and that's going to be the key thing as we move forward.